We're going to head to another room here where we have a case of a 69-year-old male with a history of schizophrenia, chronic hyponatremia with polydipsia, and recently diagnosed pancreatic head adenocarcinoma with invasion of the duodenal wall, myelinosis of the lumen seen on a recent EUS and ERCP. There was a dilated common bile duct with severe stenosis of the lower third of the main bile duct, also seen status post sphincterotomy and fully covered metal stent placement. A Whipple procedure was attempted but aborted due to adenocarcinoma identified on intraoperative biopsy of celiac access lymph node. The patient was transferred to CPMC after being admitted to a local hospital for dehydration due to gastric outlet obstruction. An EUS was performed on the 5th of November and showed a 39mm pancreatic head mass, severe extrinsic duodenal stenosis extending from the bulb to the second portion. The stricture was dilated to 12 millimeters but not stented, as the stent would cross and block the biliary stent and prevent further and future biliary access. The patient has now returned to our center for EUS-guided gastroduodenostomy. Let's go to the room.
Now we have a patient with pancreatic cancer. We already proven is unresectable, and at the time of prior ERCP by my colleague Dr. Watson noted that there was some relative obstruction of the duodenal bulb and had a hard time kind of getting through, so put a metal biliary stent and obviously wanted to maintain vigilance for gastric outlet obstruction, which has now sort of come up. And so in the interest of time, I skipped a few steps just because we're running a tiny bit behind, but I want to describe what we did. And so basically what we did first of all was we just went in with a standard therapeutic gastroscope and used a wire to cross our obstruction, and then injected contrast to see the normal downstream jejunum. If you look at the fluoro image there, you can see the metal biliary stent and the stricture extended from the duodenal bulb, essentially to the second portion of the duodenum, almost including that enteral or the biliary stent, but not quite. And so then we placed a Jagwire, an 035 Jagwire, into the downstream jejunum. And then over that, we placed a 8.5 French nasobiliary catheter and advanced it into the downstream jejunum. And that's sort of where we are. We then exchanged out the 1T, leaving the nasobiliary catheter in place. And you can see we have the pigtail looped in the jejunum there, in the very proximal jejunum, or really kind of maybe distal duodenum. We injected a little bit of contrast so you can see. And then we're going to get ready for our gastrojejunostomy. So one of the things you can kind of see on EUS here is there's that loop of jejunum, which right now is pretty decompressed and is going to make a pretty poor target. You actually can kind of see our nasobiliary catheter, I believe, kind of right here in there. So I know, for one, that I'm not in, looking at colon or something else. And then when I step on my water pedal, we see it expand. Now there's a fair amount of movement here. So, I think as others have talked about, we typically inject, we give glucagon. So we have glucagon at the ready. We're not going to give it just right now, but to try to minimize those contractions, because that's going to make life difficult for us. The other thing is I kind of want to get ready once we kind of get in place. I don't want to wait around too long, because what will be a very good window right now might not be in a little bit. So first of all, why don't we go ahead and put our Axios stent down. I typically use a 15 millimeter. One of my concerns is that with the 20s, just a little longer, and sometimes having enough of the stent within the lumen of the jejunum. And personally, initially when I was putting these in, I was upsizing them, bringing them back potentially, and upsizing them to 20, thinking that they would have better relief. And anecdotally, I haven't really seen that. They don't seem to notice any difference. I'm having a little hard time getting this on here. There we go. Thank you, Jeannie. So, again, I haven't been going initially with the 20. All right, so I have my My Axios kind of lined up. Why don't we go ahead and give that glucagon now? I've just kind of put out the end of the delivery catheter there, just so I'm kind of ready. And you know what I want is sort of a nice runway. You know, so if I'm going perfectly perpendicular into this, you know, it's going to be hard to have enough window. So this is looking a little better right here. You know, that's looking a little better. And so we're all hooked up. Kind of give plenty of water here. I want to get myself a nice, good window here. I can look on fluoro here, just kind of see where we're at. You know, again, just sort of downstream. Kind of just making sure that we look good here. We can even kind of measure the distance here. You know, about 3 centimeters, so it looks pretty good. And we're hot, right, Jeannie? Okay, so I'm going to just verify that. I'm not stepping on an empty pedal. Again, what I had was a beautiful window a second ago. It kind of closed down just a little, but here we go. And again, I want to make sure we have a nice window to get in here. And again, it's spending a little time. There's no rush. Okay, I've punctured in. I'm going to advance my catheter in. Go ahead and deploy my stent there. And you can see, I think, pretty well. I think this looks in the lumen of the jejunum. We can step on fluoro here if we want. And, you know, again, looks pretty good. So what I'm going to do is hug this up, you know, as you guys have seen many times. Go and lock my delivery device here. And we're going to go ahead and deploy. And so we're going to get ready to show endo. Not quite yet. I'm going to go ahead and deploy the Axios within the channel of my scope. And now we're going to switch to endo.
Yep.
Try to get my view here.
Do you want full endo or do you want tip endo?
Oh, that's fine. Okay, and then we have return of fluid, so I'm pretty confident that we're in the jejunum now. Yeah, we can step on fluoro here. Why don't we, Jeannie, go ahead and put a wire down. You know, if I was at all concerned about, am I actually really in the right spot, you know, before I dilate, I like to put a catheter down and inject contrast just to see. Again, if I look on EUS, it might be a little hard. Yeah, we can kind of see. Looks pretty good there. So, you know, personally, I just to start out, you know, maybe I'm just being a little wimpy, but I usually start out on a clear liquid diet for the first day, just to make sure that everything seems to be going fine. In the past, when I started doing these, I used to get an upper GI series the next day, but I think that's probably not necessary. You know, I abandoned that pretty quickly. And then, you know, I'll have them just sort of advance as tolerated, and I usually just tell them to go to a low residue diet, you know, chew up their food, you know, stay away from kind of an all veggie diet, but, you know, allow them to kind of, you know, I've been actually getting more and more aggressive with what I'm telling patients that they can eat, and really haven't had any problems. Patients are actually quite happy. And again, I initially was bringing these back thinking that, well, maybe going to 20 would be better. But I don't know that I saw a benefit, and definitely then to justify the cost of upsizing to 20. Obviously, if you start from 20, that makes sense. And, you know, it would be nice if we had a study to compare the two. So I am going to inject a little contrast just to kind of hopefully just prove that we're in the right spot. You know, I feel pretty confident, but just want to make sure. And it does look like we do have what looks to me like small intestine, and I don't believe that's colon. I think it looks good. Yeah, a little water. And then we'll go ahead and dilate up after this to 15. Yeah. Yeah, so I think that all looks good, and we get a nice, good flow into the downstream jejunum. We're actually even getting a little biliary flow. One thing I didn't really bring up, and one of the things that was sort of addressed in the kind of opening slide was, they were actually, sent to me initially for just a duodenal stent, as Chris, we really enjoyed your study looking at EUS GJ versus enteral stent, and I think that kind of helped sort of really change our practice quite a bit. We had already been moving towards GJs, absolutely, but seeing the results of your study, I think really kind of allowed us to, go to the oncologists and the surgeons and everyone and say that absolutely these are not just some fad, that actually patients do much better with these GJs. So we've been doing this almost exclusively now and almost hardly ever placing any enteral stents. But in this particular patient, what I didn't show you earlier was that on his last EUS, I noted that the cancer had gotten bigger and it was starting to get to the proximal end of the metalbiliary stent. And it was starting to kind of creep over, and the bile duct was dilating upstream, and it was about, not massively dilated, but it was about 10, 11 millimeters. And so, my concern also was if we did place an enteral stent, that we would potentially block off access to that biliary stent if we needed to. Now, it could maybe be very careful, and maybe still have access, but I suspect potentially that we may have to do something about that in the future, whether that be, now we'd have the option of going through our GJ and going sort of, antegrade or sort of retrograde up, retrograde up the duodenum, and we could still get to that metalbiliary stent and wouldn't necessarily have to do a colodoco duodenostomy, which of course would be another option, but I think just maybe another biliary stent might, oops, careful. All right. Put that back in just a little bit. Yeah, there we go. Yes, please, contrast for the balloon. All right, so we're advancing our balloon across here. And I'm going to go ahead and just, I don't think we need to get overly aggressive, but certainly we'll just go ahead and dilate up to 15. Yeah, I agree. I actually had one, it was for a pseudocyst. Placed it for a pseudocyst. It was in the, I think it was in the antrum, but the distal antrum. And then we lost him to follow-up. Pseudocyst resolved. Their local doctor basically told them, oh, you don't need to get it back in. It's good to actually just leave that in. And I think 2, if not 3 years went by, and the coating had broken down. It was so embedded in there. It was an absolute nightmare to get it out. I essentially had to do ESD to kind of cut through to get it all out. It was a big pain. So I'm definitely very hesitant to leave these in any longer, certainly than a year. Yeah, let's go up to 13.5, and then you can go up to 15. Yeah, this guy, his prognosis is not very good. Unfortunately, he's got some other kind of medical issues. I would think his life expectancy is not going to be longer than a year. So I think I would personally just leave this in and not necessarily bring it back. Certainly if their life expectancy is going to be longer than a year, maybe could consider, but I'm not sure that it's necessary. All right, you can see actually flow of bile now. So I think this looks good. I think what we're going to do now is go ahead and change out for a gastroscope. So I think we have a little time while we're waiting on the next room. So my plan is to kind of look at that bile duct. Sorry, we're just getting that nasobiliary out of there. And see, I don't think we need to do anything today as LFTs are normal. Oh, you're having a hard time, huh? Sorry, we're just having a little bit of resistance of the tube. There we go. Ooh,
Sorry,
got a little
sorry,
splash.
sorry.
No problem. All right, so so let's go all EUS. Yeah, we don't need a endo view. So here I think you can kind of clearly appreciate that metal biliary stent right here, extending out into the duodenum here, the second portion. As we follow it back up across that pancreatic head mass here, let me see if I can lighten this up a little so you can maybe see. Let's see how it looks today. It's a little hard to see. Let me see if I can adjust the settings just a little. Okay. Yeah, I think it actually looks okay here. We see a little bit of stent still continuing above the level of the mass right there. It's actually harder to get into view now than it was last time. Let's see if we can see transgastric here. And again, taking care not to mess up our nice Axia stent. Suction down the stomach here a little. Now, one of the things that actually came up was whether or not people, when you're instilling fluid, do you use water or normal saline? I've heard some concerns about, if we're giving a ton of water, could we cause problems with that? Does everyone on the panel just use water? Does anyone use normal saline? Yeah, it's a little hard to see that stent transgastric. But I think we can kind of see here that there's pneumobilia. I think that stent looks good. I don't think we need to do anything about that. Okay, so I think we can switch to back to our gastroscope and just look and make sure that everything looks good, and then we will essentially be done. All right, so I think we have a pretty patent GJ here. You can see both efferent and afferent. Let me see if can we get a fluoro image up maybe? I don't know what the audience can see, if the audience can see, just so we can kind of show. And I think at this point, we're pretty much, happy with what we have. Obviously, I'm not going to try to do anything heroic and get through this and possibly dislodge my stent. But I think if we went out this way, we'd find our way back to the biliary stent, the second portion, and then this would be the downstream here. Everything looks nice and patent. So I think that's about it. So we were talking a little bit about benign disease, and I was talking with Chris Thompson a little bit about this, but I'll throw this out to the rest of the panel. I had a patient with SMA syndrome who was not a good surgical candidate, and we couldn't get him to regain weight. And so we went ahead and did a GJ for that, and he's responded amazingly. He's now coming in telling us how happy he is eating hamburgers and everything. I even upsized him to 20, and my plan is to see him back in a year, and I was hoping that we'd be able to just take it out and his SMA syndrome would go away. But when I last saw him back, unfortunately, he still had a fair amount of stenosis. So I don't know if the panel has any advice for me on what I should do with that. Just keep changing him out yearly, every 6 months, or get bold and let it go. Yeah, I have had some scary experiences where bringing them back in even 6 months, and you'll sometimes see a little breakdown of the silicone material here, and a little pooching through, and maybe it's a little harder than you were hoping to get out. Still haven't had a problem other than that one case I told you after 2 to 3 years. But yeah, it does make me a little nervous longer than a year. When I brought him back at 6 months actually to upsize, I was actually quite impressed with when I took it out. The lumen was actually pretty small. It wasn't, like the edge procedure we did earlier where we took that out, that was nice and open. But it was, kind of like, after we do pseudocyst drainage and we used to, remove those fully covered metal stents, it sometimes can be hard to find your track again, and it was pretty small. So I do think that, because we're not actually cutting and making an anastomosis, the stomach wants to close down. So I am afraid that if we just took it out, even after a year, I'm not sure that it would stay open. I don't know the answer to that one.